Hello, my name is Stephen Myers, and I'm going to be talking about a patient that I cared for that had a case of osteomyelitis. Her initials are CAH. Her age is 44. She is female, of course. Um, Occupation is currently unemployed, but she had worked in factories and department stores off and on over the years. Her marital status was previously divorced, but she did have a boyfriend that was present at the hospital part of the time. The signs and symptoms that caused the patient to seek care were that about 3 months previous to her being on my unit, the patient had noticed some new low back pain that gradually but progressively worsened. Eventually, she began having pain in her legs as well. While motor function of the lower extremities remained intact, the patient also noticed some numbness and tingling to her legs and feet in association with these pains that were building. The patient thereafter presented for care and was eventually admitted to my hospital unit. As far as her physical exam was, she was a little bit disheveled, but otherwise well developed. Just maybe a tad malnourished, middle aged woman. Eyes were perla, no complaint of double vision, blurriness, no redness or discharge noted. ENT, no auditory problems noted or reported. No respiratory congestion or discharge noted. Oral mucosa pink and moist. As far as her neck goes, lymph nodes non-palpable, no redness or rash. As far as the skin goes, on her bilateral upper arms, there were a few track marks and a few small scabs, but no rashes. As far as cardiovascular goes, heartbeat was regular. She denied chest pain or palpitations. Pulmonary lung sounds were clear to auscultation. Respirations even and unlabored. No shortness of air noted or reported. Um, GI, no nausea, vomiting, constipation, or diarrhea. Bowel sounds were active in all quadrants. The abdomen was a little bit distended, but we'll get into why that was here shortly. So genitourinary, some complaint of difficulty in initiating urinary stream and fully emptying bladder when she attempts urination. No complaint of burning on urination. Urine clear and yellow. Musculoskeletal, normal range of motion, but increased pain to low back and legs with movement. No swelling noted to joints at this time. Neurologic, alert and oriented times 3. Some numbness and tingling reported to bilateral lower extremities. So as far as her medical history, um, she her one of her biggest items, unfortunately, was IV drug abuse, hypertension, hyperlipidemia, anxiety, depression, Hep C, Hep B, and previous abscess to the arm and cellulitis. Surgical history: C-section times 2, cholecystectomy. Family history: her mother, who's deceased, age 65, hypertension, osteoarthritis, stroke. Father, deceased at 71, hypertension, hyperlipidemia, MI, diabetes, and she has a brother living with hypertension and diabetes. Her home medications include fluoxetine, 20 milligrams PO daily, lisinopril, 10 milligrams PO daily, and atorvastatin, 40 milligrams PO daily. And inpatient, she is receiving some oxycodone, 5 milligrams PO every 4 hours, PRN. As far as her pathophysiology goes for this osteomyelitis that she's been determined to be experiencing in her low back, spine, um, it's so because of her illicit IV drug use, she had repeatedly injected her bloodstream with bacteria through dirty needles or contaminated IV solution. The bacteria thereby introduced likely traveled through the vascular system and deposited in the bone of her lower spine. There, the bacteria grew, infecting the bone and forming an abscess near the spine that had begun to put pressure on her spinal nerves. That nerve pressure is the main reason this patient had been experiencing pain, numbness, and tingling. Some risk factors, generally speaking, for osteomyelitis include, as in this case, IV drug abuse, diabetes, peripheral vascular disease, cellulitis, implanted orthopedic hardware, and traumatic injuries. The incidence of osteomyelitis has been measured at 24.4 per 100,000 person years. So clinical manifestations typically associated with osteomyelitis can include pain in the area of the infection, redness and swelling at the infection site, and fever. In the case of my patient, she did not have fever, redness, or obvious swelling, but she certainly had the pain. And due to the proximity of her osteomyelitis to her spinal nerves, she was beginning to experience other symptoms like difficulty urinating independently and sensation anomalies. Many diagnostic tests are associated with osteomyelitis. Blood tests like a CBC could show elevated white blood cell count, indicative of infection. C-reactive protein elevations could also indicate infection and inflammation. Various scans are also done of the area of suspected infection. An MRI being the one that provides the highest level of information. An MRI scan usually shows whether an area of infection has spread to the bone itself, officially diagnosing osteomyelitis, and shows if there is any pockets of pus or gas around the infection that might benefit from lancing or an incision and debridement, IND. In the case of my patient, her white blood cell count and CRP were elevated, and MRI confirmed the presence of osteomyelitis. The medical treatment recommended for osteomyelitis is long-term IV antibiotics, up to 6 weeks in duration. Patients were once recommended to have 12 weeks of antibiotics, but research has shown 6 weeks of therapy to be equally effective. When I worked with this patient, she was receiving IV antibiotics in accordance with the recommended time frame. This patient had a referral to infectious disease to manage her infection. Patients without a history of IV drug abuse are sometimes permitted to continue IV antibiotics at home once they are stable, but this patient's recent IV drug abuse history was a contraindication to that possibility. With my last encounter with this patient, she had lost the ability to urinate independently and required the placement of a Foley catheter to support urinary elimination. Unfortunately, after a few weeks of treatment, thereafter, this patient was confirmed to be abusing illicit IV drugs while an inpatient and was subsequently administratively discharged before the successful completion of her recommended therapy. Her current disposition is unknown. The case of this patient is unique amongst the patients I have cared for. When this individual began abusing IV drugs, I very much doubt that she was aware that her actions would take her down a road that would lead her to not being able to urinate on her own, or that it would lead to chronic liver disease, as she now has hepatitis. This case accentuated to me the very severe potential physical consequences of IV drug abuse. Having worked in this particular venue of nursing of the med-surg unit for 2 years, I've seen a host of the physical complications of illicit IV drug abuse. While I had always known IV drug abuse was bad, working in this practice area really drove home to me just how exceedingly bad IV drug abuse is physically, emotionally, socially, and on so very many levels of life. This realization increases the urgency in my mind of helping individuals addicted to illicit drugs. If the circumstances are right, I might even share with patients involved with IV drug abuse the complications I have seen due to illicit drugs as part of my encouragement for them to stop, change their behavior. And it also increases my support for societal initiatives to support people recovering from addiction and otherwise combat the terrible scourge of illicit drug use. Um, so that's presentation, and wish you all a good night. Thank you for viewing. Bye bye.